Good morning, everyone. We're going to go ahead and get started because 8 o'clock, there's a lot to talk about, and we want to make sure we have enough time for everyone. So I want to welcome you to our Snap Talk panel, Disparities in Regional Anesthesia and Pain Medicine. My name is John Patton, and I am a clinical assistant professor in the UCLA Department of Anesthesiology and Perioperative Medicine. I have no financial disclosures, but I welcome any finances if anyone wants to give me, give me some. So learning objectives, we're going to start by understanding the differences between race, ethnicity, culture, and elaborate on why it is important in the context of patient care and pain management. Then we'll illustrate the differences in delivery of regional anesthesia and pain medicine in various subspecialties such as pediatrics, obstetrics, and acute and chronic pain medicine. And lastly, we'll discuss solutions to mitigate and eliminate these disparities at the patient, physician provider, and healthcare systems level. So I'll be starting with introduction, and then we'll talk disparities in regional anesthesia and pediatrics, adult regional, obstetrics, and then finally solutions. So we have Dr. Carla Wyatt and Thompson, and I was just informed that she's at Cincinnati Children's now, no longer Texas Children's. She's going to be discussing pediatrics. Dr. Damian Archibald is going to be discussing adult regional. He's from NYC Helmers. Dr. Chantal Pyram-Vincent from Mount Sinai will be doing OB, and Dr. Rodney Gabriel from UCSD will be talking solutions, and hopefully afterwards we'll have time for Q&A. So we're just going to start by discussing some definitions or terms. So race is a social construct used to group people. Race divides human populations into groups, often based on physical appearance, social factors, and cultural backgrounds. So health and healthcare disparities refer to differences in health and healthcare between groups that stem from broader inequities. Health equity is defined by everyone having the opportunity to attain their highest level of health. In this illustration here, giving everyone the same bike would be equality, recognizing that the needs of each individual are different, and in order for each to have a similar chance at success, we would have to meet each individual where they are and equip them with what they need. That would be equity. So health equity requires removing obstacles to health. Social determinants of health are the conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risk. So I like this term, social influencers of health, more so than determinants. So Dr. Gregory Simon, a Kaiser psychiatrist and researcher, argued against the use of determinants of health because determinants makes it sound as if it's one's destiny. The term factors influencers, he argued, should be used instead of determinants. So let's discuss some literature here. When we think about life expectancy, we often consider things like one's genes, gender, lifestyle choices that he, she, or they make. I'm sure no one here is surprised by me saying that the zip code you were born in may matter the most. According to data from NYU, Chicago is the city with the largest disparity. Life expectancy varied by up to 30 years between zip codes with the highest life expectancy and those with the lowest. So looking at this map here, it is not surprising that the south side of Chicago, which is home to majority people of color, are the areas with the lowest life expectancy, most food deserts, and highest rates of unemployment. These trends are seen all around the United States, in cities like Washington, D.C. and New York. How does where you live affect one's health? Well, exposure to pollution, lack of access to fresh foods or food deserts, and quality medical care are a few examples. No surprise that cities with high racial segregation have the widest gaps in life expectancy. So the Kaiser Family Foundation estimates that by 2050, over half of the US population will be people of color or persons of color. Our patients are becoming more diverse. We see the biggest percentage gain here with the Hispanic population. Of course, it's important to mention that racial and ethnic groups are not monoliths, okay? These groups are highly diverse and culturally divergent collections of individuals. This was data published in 2024 from the Kaiser Family Foundation focusing on language barriers in healthcare. The survey included over 6,000 adult participants. 62% were Spanish-speaking, 22% Asian. It was weighted to match the Census Bureau demographic data. When discussing health disparities, it's important to consider how limited language proficiency drives health disparities or impacts health equity, especially as our populations become more representative of people of color. So according to this survey, individuals with limited English proficiency are more likely to be uninsured, report health as fair or poor, have greater barriers to access to care or health care. I'm just going to highlight a few findings from this survey in the interest of time. Adults with limited English proficiency are less likely to report healthcare providers involve them in decision-making about their care. You can imagine what impact this may have on the patient-provider relationship and downstream effects: less trust, lower satisfaction, and lower quality of care. Almost 40% of the respondents said their recent healthcare visits were with a provider who spoke their preferred language. And you can see here, when half or more healthcare visits are with a provider who speaks their preferred language, there are fewer language barriers. So understanding, for example, understanding instructions given to them. Adults with limited English proficiency who have more visits with language concordant providers are more likely to say providers ask about social factors, such as their work, housing situation, or access to food or transportation, social influencers of health. So how may this impact health disparities? Well, on the far left here, this was a study published in 2018 that showed that patients with limited English proficiency in the ICU had lower rates of do not resuscitate orders, lower rates of comfort care measures ordered before death, and lower rates of advanced directive completion on ICU admission. On the bottom right here, Dr. Gabriel's group down in UCSD demonstrated that Hispanic patients had significantly decreased odds of receiving regional anesthesia for thoracic surgery compared to non-Hispanic patients. Sorry, Damien, I'm not trying to steal your thunder. I know you're going to be talking regional. So we know different individuals experience pain in different ways. These experiences are influenced by culture, racial and ethnic backgrounds, traditions, religious beliefs, socioeconomic factors, and more. Responses to pain is highly variable. We know different cultures express pain in different ways. Looking at this pain rating scale, not everyone cries at 10 out of 10 pain, shown here, or smiles when they are not hurt. Some cultures may be much more stoic than others, while others may be much more expressive. Some may overreport pain for fear providers may not believe them or respond. Of course, in attempts to become more culturally competent or sensitive, we must be careful to avoid stigmatizing patients or discriminating. Framing cultural differences in response to pain in this way is problematic. You may recall in 2017, this nursing textbook went viral. The reason it went viral is because it listed a number of culturally insensitive stereotypes about how different cultures experience or express pain. I won't read them, but this was being taught to nurses in 2017. Due to the backlash, the publishers issued an apology and removed the material. This study was particularly interesting. The investigators examined whether racial bias is related to false beliefs about biological differences between blacks and whites. Study 1, an online sample of 92 white individual laypersons, and study 2 included white medical students and residents. What was found was that not only did the white laypersons believe there are biological differences between blacks and whites, but white medical trainees do as well, which was related to racial bias and pain perception. Furthermore, medical trainees who believe that black people feel less pain showed bias in treatment recommendations. Again, this was 2015. When we talk health disparities, we must not forget persons with disabilities. This was a report from the World Health Organization that showed persons with disabilities have higher rates of chronic conditions, poor overall health, reduced access to care, lower utilization of preventative services, and higher mortality rates than persons without disabilities. I'll end with this, as there has been increased enthusiasm for incorporating large language models into our workflows. These investigators reviewed the literature of demographic biases and medical large language models. Some of what they identified was prevalent bias types. They found LLMs continue to reflect societal biases. In addition, use of LLMs can perpetuate biases. So this may worsen existing health disparities. It was noted that bias detection is improving with newer models, but there are still many challenges. Thank you. Oh, I'm sorry. I went wrong. They had the wrong order. Give me 1 second.
I'm scared.
There you are.
Just turn it on.
Cool.
Repeat. There you go.
Just go here.
Good morning. Thank you, everyone, for coming. My name is Carla Wyatt Thompson. I am the Director of Regional and Acute Pain, the Acute Pain Service at Cincinnati Children's. And I have reason to believe that we all care deeply about people, especially those of us that have embarked on the career of medicine. And so what I want to do in this next 10 minutes is traverse how we look at regional anesthesia and do the outcomes that we provide affect children. So why is, let me see here. I have no disclosures. Why is this topic important? A lot of research has shown that poorly managed pain for children in the perioperative arena has significant biophysical, psychological, and social influence as these children leave, meaning a simple anesthetic where a child doesn't receive analgesia can result in that child having a long-standing fear of the physician community. It can affect the psychologic and behavioral development of that child. And so we owe it to the children that we see to make sure that we're providing equity in the care. The other thing is that we know from a lot of data in the adult world as well as the pediatric world that some of these social influencers of health will affect certain populations. And so we're embarking on research to determine, can we tease out the children that might be more predisposed to developing or encountering some of these things in the perioperative realm? And then highlighting some of the gaps in what we understand in pediatrics and looking into opportunities that we can mitigate some of these concerns. So what is known? I'm going to traverse what's known in the pediatric arena of regional anesthesia in a chronologic fashion. And again, this talk is focusing on regional anesthesia and pediatrics. This was the first expose that was done in this area. This was out of the University of Michigan in 2017. The authors wanted to look into if there were racial differences in how PACU pain was recovered. So are we treating individuals the same as they're recovering from a variety of outpatient ambulatory surgeries? There were two cohorts that were looked at, so 771 children, 80% of which were white, another 20% were non-white. The non-white group included Black, Latino, Asian, Island Pacific, and American Indian. What they did was they streamlined a variety of surgeries that you'll see here in this graph at the top. The comparable data between the two groups of children, so non-white and white, were about the same. The only difference that was noted between the two was that the non-white children had substantially higher rates of overweight and obese kids. Other than that, the kids were matched appropriately. So I'm going to focus on a couple of the outcomes they looked at. The biggest was opioids. Were non-white and white children receiving the same opioids in the recovery period? The next was pain scores. Did the non-white versus white children have comparable pain scores in the recovery? And then particular to what we're looking at, what about regional anesthesia? So what the study found was that there was no statistical significance in the difference between reported moderate to severe pain in non-white versus white children. 771 was the cohort. When they looked at opioid consumption in the PACU period, the non-white children actually received more opiates than the white children received. So IV opioids weren't spared or reduced in minority children. And the third outcome, which I have highlighted here, there was no difference in the receipt of regional anesthesia. And you see there that there was a good number of urologic and ortho procedures that would have been eligible for regional anesthesia. Moving on to 2019, this was the next study that incorporated regional anesthesia. This group was out of the MD Anderson in Houston, Texas, and they were looking at blood product management and epidural analgesia for children under the age of 19 that were going to be undergoing large abdominal surgeries or pelvic surgery to resect tumors. And this came from adult data, again, that showed some differences in blood transfusion or blood utilization product in non-white versus white. So this cohort was 139 patients. This was a retrospective study as compared to the study that Buki did in 2017 I just talked about that was prospective. So retrospective study, there was 42% that were non-Caucasian. That's what they used to describe their population, or non-white, and then 58% that were white. What were the outcomes that they wanted to look at? They wanted to determine if there was a difference in intraoperative and postoperative pain in terms of analgesia that was received. They wanted to determine if there was a difference in patients that received epidurals versus no epidural, and they wanted to determine if there was a difference in blood utilization. On the first univariate comparison that did, that first model, it did show that white patients had a higher propensity to receive regional anesthesia in the form of an epidural. However, when they teased out pre-op coagulation factors and coexisting abnormalities that might make you ineligible for an epidural, there were no differences in the patients that received epidurals. There were no differences in intraoperative opioid as defined by the morphine milligram equivalents, and there were no differences in the pain scores in the first 24 hours postoperatively. So again, smaller N, retrospective, but we see no difference in regional anesthesia being offered, no differences in pain between non-white and white. So we move on to an area that many of pediatric people are well-versed with. It's the parents. And the parents dictate a lot of what we do. And I think when we step back and think about it, it makes a lot of sense that if an adult has poor care, poor interactions, mistrust of the health system, they're going to then counter-transfer that to the care they want for their child. And so this study was done in 2020. It came out of Children's Hospital of Los Angeles. They wanted to see the impact of family-centered care. So when we engage parents with different modalities, whether it's devices that communicate, a person that communicates, making sure that language isn't a barrier, we're all explaining things in a way that's synonymous. Is there a difference in who will and won't receive regional anesthesia? And there were 3 dimensions that this study focused on, which I thought were very important. There was a non-white versus white group. The non-white group included Latino, Latina, Black, and Asian children. 4,700 children, a little over 4,700 children. And here, the 3 domains were poverty, and that was defined by the children that were on government insurance versus private insurance, limited English proficiency, and then that last domain being the race component. So what did this study show? Well, this study showed overall that white and Asian patients were more likely to accept a caudal block for their urologic surgery for their child. 60% of Latino patients and then 60% of Black patients said no to block. And going even further, English-speaking patients were more likely to receive regional anesthesia for the caudal block for that urologic procedure. 65% of Spanish-speaking individuals, or those that were defined as limited English proficiency, declined the block. And households that were under the poverty level were more likely to decline regional anesthesia. So again, this doesn't speak to what was offered, but it gives us some insight into what parents think about so that we can kind of question what we're missing and how do we communicate these things effectively. And we'll talk about that a little bit more. 2 minutes left? Okay, so I'll go through this pretty quickly. This was the largest study that was done, came from Stanford Lucille Packard's 25,000 children. 3,000 of them received regional anesthesia. They essentially found no differences between the white and non-white cohort in terms of postoperative pain, in terms of intraoperative analgesia, and in terms of the receipt of regional anesthesia. And then this was a scoping review that was done in 2021. This is the most recent that we have out there. So if you look, I put this up here so that we could see all of the places that were involved. So Seattle, Cincinnati, Philly, Ann Arbor, Durham, Houston, Palo Alto. So it hit kind of every area of the United States. And most of these studies, all of these studies in the regional arena showed no difference in opioid consumption, no difference between racial groups with the receipt of regional anesthesia. However, the N is low, so there's only 10 studies that are out there. So I wanted to quickly highlight some of the institutional perspectives that we have. At Cincinnati Children's, we do quality informatics and tracking of social determinants of health. All of the children are screened for it. And so we've set up a database that uses area deprivation index, where area deprivation index, if you're not familiar, is a validated metric that the U.S. Census Bureau will use to determine vulnerable neighborhoods. It's based on things like housing, access to transportation, minority status, socioeconomic status. And so we wanted to determine if utilizing protocols helps reduce or mitigate risks that might arise with regard to disparities in providing regional anesthesia. So retrospectively, we looked across 3 years. We had 1,154 patients that received regional anesthesia. The groups were white, and then we had in our non-white group, Black, Asian, Hispanic, and other. We assessed for 4 major domains. So postoperative pain on day 0, and that was defined as the amount of time a patient spent with a pain score greater than 4 in that first day. This is pilot data, so soon to come, but pilot data with my colleague, Dr. Vidya Chidambaran. And then we looked at postoperative pain day 1. We looked at morphine milliequivalents on day 0 and day 1. We looked at patient satisfaction on day 0 and day 1. And then we looked at pain scores as it relates to the area deprivation index on day 0 and day 1. So do we see any differences in pain with race? Do we see any differences with socioeconomic status as defined by the area deprivation index? And do we see any differences in patient satisfaction? The only place that we found a difference was in pain area under the curve on post-op day 0. Our white patients and Hispanic patients reported higher pain scores in that first 24 hours after surgery. Asian patients reported lower pain scores in that first 24 hours after surgery. However, post-op day 1, pain scores were equilibrated. There was no difference. Opioid consumption was equilibrated. Day 0 and day 1, there was no difference. And then no difference in patient satisfaction. So all of these things highlight that in the pediatric realm as it relates to regional anesthesia, we are not seeing some of the differences that have been noted in the adult world. That being said, these studies are limited. All of them have been retrospective except one. And then when we looked at the areas that many of these studies were done in, they were urban areas. So we don't know if this extrapolates into more rural communities. And so it's hard to draw conclusions based on what we have available. The important thing I leave you all with is this data that we have, one, assures us that we're in the right direction in the pediatric realm, but we want to maintain our awareness. And so some of the things to think about are how protocols can help us to streamline care so that if everyone comes in and they're coming for a particular surgery, the surgeon is on board with it, we offer the same thing. Does this help that patient, that pediatric patient, proceed through their course with optimal pain control? Thank you.
Morning, everyone. I'm Dr. Damien Archbold. I'm an anesthesiologist at Elmhurst Hospital in Queens, and I'm going to take a slightly broader lens on this question of disparities in regional anesthesia and acute pain for adults. And I had a mentor tell me, keep your mind open, but not so open your brain falls out. I'm going to try to reflect on my experiences working in different hospitals, use some data, and also point to some of the solutions that might start to address some of the issues that some of the previous speakers have brought up. So the aim of this talk is to overview some of the systems level influences on access to regional anesthesia and acute pain medicine in adults, and also reflect on your and our role in addressing some of these structural factors. And I don't have any financial disclosures. So we're going to define health systems and how they influence access to regional anesthesia. I'm going to talk about some of my own experiences working in different systems. I've trained in New Zealand, Australia, Ireland, and also within different systems in the US. And we'll use some data just pointing out some of these disparities and what we might be able to learn from other countries and other systems. So what is a health system? Different definitions. And the Agency of Healthcare Quality and Research defines it more narrowly than the World Health Organization. The World Health Organization looks more holistically at all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. That's quite broad. Whereas AHRQ says it's a group of healthcare organizations jointly owned or managed. The Harvard Business Review goes even narrower and says it's a collection of health assets with a common brand name. I think most people in this room agree that the aim is to provide universal coverage to every person, extending that to regional anesthesia and acute pain. And that's a definition of universal coverage, including the final phrase, without financial hardship. Here is a framework for what different systems around the world, ways that they attempt to provide universal coverage. Nowhere is quite at the very top left. We're at the bottom left. And I'm going to make a pitch at the end of why moving towards this top left, having a single payer system, is going to improve access to regional anesthesia. Does anyone know who this top person is? That's Mary Bassett. She was the health commissioner in New York for 4 years, and she, along with other institutions, issued the statement in 2019, Racism as a Public Health Crisis. And anyone know who this next fellow is? This is Don Berwick from the Institute for Healthcare Improvement. If you're interested in health systems, he has a fantastic podcast. But he was also the leader of CMS, and I think this quote is really relevant to this talk. Every system is perfectly designed to achieve exactly the results that it gets. So when you're hearing some of the statistics and descriptions of disparate outcomes and processes and access to regional anesthesia, consider that quote. I would recommend, if you want to do a deep dive in this topic, this is the most recent summary of the evidence. This is from J.B. Liu and Steve Haskins at HSS. They have a narrative review of racial and ethnic disparities in regional anesthesia in the United States. And as previous speakers have mentioned, all of these studies are retrospective. The data is quite incomplete. It tends to focus on urban areas and academic medical centers. The larger data that we have stems from Premier database and from NACOR, from the NISQIP and TQIP. These are all databases that are quite narrow and don't give us a very good understanding of the broader disparities from rural to urban to community hospitals. So we're looking in a very small window at some of these disparities. But even when we're looking at those, we see quite marked variations in access to regional anesthesia, even within the same system. And one of the takeaways from this narrative review is that there are institutions where no one receives regional anesthesia and they don't have acute pain services. And often they're excluded from these data. So Dr. Del Pizzo, she's a pediatric anesthesiologist, was looking at this question and had to exclude a number of hospitals because there was no reporting of any regional anesthesia. So the takeaway is that the data that we have to compare, even in our system, is very poor, much less across different systems or across different countries. Although, do we have a system in the United States that promotes regional anesthesia and is perhaps more advanced than some of even our academic medical centers. And the military health system is a single-payer system, meaning that active military service members, their family, and retirees have access to a single payer where they have clinical practice guidelines that incorporate regional anesthesia into their multimodal analgesia pathways. And the person that you're seeing here is Trip Buckenmeyer. He pioneered the use of continuous peripheral nerve catheters in forward military bases in Iraq and Afghanistan, and the repatriation of injured soldiers with limb injuries with continuous peripheral nerve blocks from Landstuhl back to Walter Reed, where he's the director of regional anesthesia. And this study at the bottom notes that here in San Antonio, the only level 1 trauma center in the Department of Defense disproportionately trains CRNAs and anesthesiologists in regional anesthesia practices, and they're much more common in the military health system. Although even their data is poor, and they make the point that the anesthesia procedures aren't coded and billed for, which is where most of this data comes from in the Premier database, for example. Just zooming out to some systems, I just wanted to quickly highlight that there's a report from the Commonwealth Fund from 2024 looking at 10 different health systems, 10 different countries, and they looked at 5 metrics. One of them was equity. This is a composite of all these different metrics. Part of the point was that each system can learn something from each other, but you can also see that the United States is an outlier. And there was a talk yesterday by the chief of anesthesia of the Mount Sinai Health System, where he was making a similar point that the United States health system, the outcomes and the quality versus the cost, which we can see on this slide, mean that we have really low value care. And so what can we learn from other systems? I worked for 2.5 years in northwestern Australia for the Royal Flying Doctor Service, where regional anesthesia forms a part of our multimodal analgesic pathway for, I'll talk about hip fractures. So if a patient fractures their hip in Kununurra, which is close to the border of the Northern Territory with Western Australia, typically a remote area physician will place a fasciitic catheter so that we can bolus the catheter with dilute ropivacaine. Sometimes it will take 10 hours to transfer a patient, stopping to refuel and pick up other patients, bringing them to Perth, so we can re-bolus the catheter. And this is part of our clinical practice guidelines. But in New Zealand, there's a similar system with paramedics, so they place single-shot fasciitic blocks for suspected hip fractures before bringing patients to the emergency department. So patients have access to pre-hospital peripheral nerve blocks. And the bottom slide here is from the American Academy of Orthopedic Surgery. They have pretty strong evidence and a high recommendation to place peripheral nerve blocks preoperatively for hip fracture patients. But I found that that's quite unusual in the United States, although we have poor data to demonstrate the variations in practice across the United States. Does anyone recognize this? Yeah, it doesn't look like this anymore. And I'll just, I don't have much time, but I'll just mention that war and targeting of hospitals and healthcare workers is a potent tool to minimize the likelihoods that someone has access to regional anesthesia and acute pain. I worked here in 2018 and 2019 teaching local nurses and doctors regional anesthesia techniques, some of whom have been subsequently targeted. So I'll just keep going with the New York City hospital landscape. There's wide disparities across New York City that I've experienced, and they also are characterized in a number of studies by Mary Bassett. But also, I just wanted to point out that we have the largest municipal health system in the country. So there's 12 hospitals. I work at Elmhurst Hospital, but I did a fellowship at the Hospital for Special Surgery in 2018, where 85% of patients having surgery have some form of regional anesthesia. They're a global leader in research and education of regional anesthesia, and one of the papers I referred to, and many of the papers looking at this question of disparities in regional anesthesia are published at the Hospital for Special Surgery. They have 45 operating rooms and 150 beds. And after the experience of learning and training with these world experts, I went to Elmhurst Hospital in Queens in 2019, which you might have seen on the news at the start of the COVID pandemic. We were the epicenter of the epicenter, where very few patients had access to regional anesthesia in 2019. We've had a series of training sessions and training of residents and other attendings, interdisciplinary training with emergency medicine to steadily increase the number relative to the other H&H hospitals in New York City. So we've had a 270% increase in the number of nerve blocks performed. And I think that's we're an outlier now, but it still begs the question, how do we improve this system to ensure that every patient at every one of these hospitals and across New York City have access to regional anesthesia? And so I would say better data. There's some potential with EPIC and Cosmos prospectively measuring the quality and safety and outcomes of regional anesthesia. And I would also say the clear answer for me is moving to a single payer system, which New York State is closest to with the New York Health Act. But I'd like to save some time for questions at the end. Please get in touch, reach out to me via the email. Thank you very much.
Morning, everybody. I'm Dr. Pyram Vincent. I practice at Mount Sinai in New York, and I'm an associate professor there. So I'm going to be talking about disparities in OB anesthesia and analgesia. I'll start out by saying that, we're all going through different populations, but women, birthing women in the United States come in with a different perspective. Of course, I have no conflicts. I wish I did. If you have any, let me know. So the way I'm going to present this talk is first, I'm going to go through how these women are different than other populations that we go through, that we take care of. I'll talk about the disparities. I'll talk about possible causes of these disparities. And then finally, I'll end with solutions that are specific to OB anesthesia. So I'm looking, and age-wise, I don't see too many people who've delivered, but childbirth is one of the most painful things that a woman will go through, and it's one of the most common reasons for hospitalizations in the United States. That being said, about 20% of women actually report having mistreatment during their care, and that's all women. So this was a study done, a survey conducted by CDC, and they found that the most cited examples for mistreatment were that patients felt that they received no response to their requests for help, they were scolded, they felt threatened from either people withholding treatment for them or actually making them accept unwanted treatment. So for example, telling them that they need to have a C-section. Baseline, just getting to everybody on the same page, neuraxial anesthesia is the preferred method for anything obstetric. So whether that is for labor, childbirth, or that is having a cesarean section. And we have multiple organizations that have put this out. ACOG and ASA put out a joint statement saying neuraxial is the most effective and flexible treatment modality. World Health Organization, SOAP, have also endorsed this. People have different methods based on their institution, but the point is epidurals, mainly for labor analgesia, and spinals or epidurals for cesarean sections. About 75% of patients in labor receive neuraxial anesthesia, 96% of the time for cesarean sections. And the request is basically the only indication for it at any point in time. The patient can be fully dilated. If they request an epidural, we usually place it at our institution, okay? And the reason is because you want to avoid the risk of general anesthesia if it actually progresses to a C-section. So I'm going to start. OB is different in the sense that this has been studied for a long time. Disparities are really well known. So this is kind of going to breeze through a lot of different studies for a lot of different things. So this first one is a systematic review with over 13 million patients. They included about 24 studies, one randomized controlled trial, similarly to the others, a lot of observational studies. It included US and UK. 16 of these actually applied to labor analgesia. This specific graph is looking at Asian versus white and shows that if you are Asian, there's a 0.8 odds ratio, meaning that you are less likely to receive a neuraxial anesthesia. And this is from compiling all of these different studies. I will say there are a few that look like there were no change, but those tended to have smaller ends. This is the same study, but they actually looked at USA-specific studies. And with all those that were non-white, they found if you look at Asian, Black, or those who self-describe as other, they had 0.82, 0.72, and 0.69 respectively. So usually people that are other, it's really hard to actually capture that data, but they're always lower. You know what I mean? So it's kind of like we have to try our best in our institutions to try to capture those people because they kind of get lost to the system and their care is typically less than the others. I do want to note that there were no differences as far as the Hispanic patients in some of the state, differences have been seen in like single institutions or in like regional databases for Hispanics, but it wasn't seen in this. There is a large amount of like state variation as well as far as usage of neuraxial anesthesia, but even when you account for the state variation, it doesn't account for the disparities that we see. I also want to mention the UK, just because the UK was included in the other study as well. There are a lot of differences between us and the UK as far as like insurance, population-wise, and their labor analgesia use. They actually use epidurals about 21% of the time. Their population is different in that it's majority white, 8% Asian, and 3% Black. So in that case, a lot of the disparities they saw were more with Asians. And I do like that they don't conflate their data, like it's not Asian, it's not Black. It's kind of like they break it up by like country of nationality. So for example, those who are Pakistani or Bangladeshi had more disparities than others. Mm-hmm. This graph that I also showed is based on like natality data in 2015, and it has over 2 million birthing persons specifically in that year. And the range that I speak of, so for example, Maine had like a low epidural anesthesia rate, and that's about like 37%, whereas you have like Nevada who has 80%. So trends have been increasing, and neuraxial analgesia placement has increased for labor, which is great, but you can still see people who are lagging, right? So like the bottom two, you can see that those who are Native Hawaiian or Pacific Islander are still lagging, as well as those who are American Indian or Alaskan Native. This study, I'm sure a lot of people have seen before. Now we're getting to like cesarean sections and mode of anesthesia. This basically shows that those who are minoritized have a higher risk of having a general anesthetic. And if you look at model 4, even when you account for comorbidities, age, insurance class, BMI, et cetera, it is still 1.7 times the odd ratio for a Black woman having a general anesthetic. But you kind of have to wonder why, right? Like, why are you having a general anesthetic? Is it because of decreased use of neuraxial? Is it because of emergency indications, right? So we kind of have to ask these questions and investigate this. Or is it bias? Is it racism? Is it that you're pushing these people to do that, right? So now we're gonna look at racial disparities in postpartum pain management. So this systematic review kind of looks at, there was a systematic review, and this study is just one of those studies that were in there. So the systematic review was done by Craig et al., and it included this article and 7 others, and they looked at 3 main domains. The first was postpartum pain severity. The next was frequency of pain assessments, and last was analgesic prescribing practices. So this one kind of speaks to the analgesic prescribing practices, and you can see that regardless of pain score, right, with Hispanic women having higher pain scores than those that were white, and they were less likely to actually receive opioid prescriptions, and this is in morphine equivalents. Disparities were also observed with minoritized patients having less frequent pain checks. And in the UK study, they actually went even further. So they went past just postpartum, but they went out to like 30 days. And what they found were that Asian patients had scores of greater than or equal to 7 after 24 hours, even at rest, with odds ratio of 1.7. And even if you go out to 30 days, the odds ratio was 2.42 for them having pain at rest, okay? And 2.32 for movement. So, and this is really important, because if you're having pain 30 days after you had surgery, right, this is like acute on chronic pain, and this is gonna decrease immobilization, this is gonna decrease the ability for you to take care of your children, right? These are things that have like a larger impact. And I will add that this can add to mental health, which is now the leading cause of obstetric death. Okay, complications. Complications happen. Of course, they happen more in minoritized patients, all right? Sorry, I'm saying like a lot of depressing things here. But how do you treat these complications? Post-dural puncture headaches, they happen. They happen in everybody, 1% of the time. But you have to take care of them, right? So epidural blood patches is the gold standard for how you take care of this. Surprise, surprise, who gets them less, right? So again, minoritized women get them less. What are the drivers? How can we change this, right? So there are patient-level drivers, clinical or provider-level drivers. Those are the easy ones to solve. Anticipated use is actually really important. Toledo et al. Actually put out a study that patients, based on their anticipation, were more or less likely to actually want an epidural. And they found that Hispanic patients were 51% of them 51% of them anticipated having an epidural versus 83% of white women. So working on that in advance can actually help them get more. Okay, and language matters as well. So even if you compare Hispanic patients themselves, those that primarily speak Spanish are less likely to anticipate getting an epidural. So then we're gonna look at structural ones next. Institutional level, your neighborhood, we talked about zip code, how you're serving to minoritized communities. So basically, hospitals that have a high serving Black population are bad to anybody who goes there, right? So, and the bad part about that is that 75% of Black women deliver at medium to high serving Black institutions, and anybody who goes to those institutions actually has has increased chances of severe maternal morbidity and mortality. Policy level wise, postpartum coverage, right, and how often you can see these patients, and Medicaid cuts that are pending. So there's a study about structural racism index and labor analgesia use. It used these 3 components to kind of figure out what is structural racism. It was multidimensional, so it kind of looked at educational level, it looked at unemployment rate and incarceration, and they compared the Black to white inequity. Areas that have more structural racism in them, regardless of what race you are more likely to have people that do not receive neuraxial anesthesia. So tercile 3, they kind of split them into 3 main groups. had a 72% rate of having a neuraxial anesthesia. I'm going to be really quick. So basically, these are things that you kind of go through to work through these, right? So you have to identify where the problem is, use evidence-based interventions, invest in them, and try to incentivize people. And that's exactly what we're trying to do. So on a patient level, you really want to listen and take off those headphones. You really want to educate as much as you can. You educate your people, you educate the public, you try to get the community involved. Provider level, longitudinal training is the key. You can't just do these one-time sessions. Institutionally, maternal equity dashboards to be created, enhanced recovery, as we talked about before. And I will say that on a structural political level, this has started to already be done. There is a Black Maternal Health Caucus. They are doing the Mom and Bus Act, which has 13 bills that are in there. We do have SOAP centers of excellence. There are CMS incentives that they're trying to push with that. That being said, I'm gonna go, but I'm gonna say that investing in advocacy and things like that and speaking to these legislators is the key.
Hi, everyone. I'm Rodney Gabriel. I am the associate professor and vice chair at UC San Diego. I also am the medical director of our outpatient surgery center, and then I was division chief of regional anesthesia for 7 years. And so I get the fun task of telling you, everybody, okay, how are we going to fix this? I think there's a lot of overlap of the other talks where we did talk about some solutions, and you know. To figure out solutions on how to mitigate disparities, specifically in regional anesthesia, you know, the first step is, are there any, right? And so when you see them, then you have to ask, why are they there, right? Because if you want to solve a problem, you have to know the cause of it so that you can do an effective approach to it. And so this is sort of the approach I'm going to take with this talk, where I'm going to tell you, like, are there disparities, and then say why they're happening, or you know, why we think they may be happening, and then talk about focused solutions. You know, we haven't been looking at this for very long in terms of disparities specifically in regional anesthesia, and this is a bar plot just showing the number of publications that have been increasing over the last 7 years related to regional anesthesia, obstetrics, even pediatrics. And so the last 2 years, actually, I don't put it up here, but there's a lot more. And so we're seeing a big uptick on of people studying this, and this is all related to access to databases. Now, when we talk about disparities in regional anesthesia and the papers, it's important that you look at the data set that they use, because there's limitations to data set. And the reason why that's important is because if you want to ask the reason why this is happening, you have to actually look at the data set. And so you see a lot of these disparity studies looking at the NSQIP data set. Raise your hand if you're familiar with NSQIP. Okay, so it's a large surgical data set. It has many diverse institutions. It's focused on surgery. But there's minimal granularity in regional anesthesia details, and you don't necessarily have access to individual institutions. Everything is all lumped together. And so when you look at a conclusion from a study with NSQIP, you're looking at all data lumped together, and you can't look at it institution-specific or state-specific. And so if you think about that, there's limitations on answering questions of why there's disparities. But nonetheless, what we see was when we looked at mastectomies, right, those getting mastectomies, there was 2 studies. Essentially, in this left, there's a forest plot. Patients that were Black, Asian, unknown race, Hispanic, all had decreased odds of receiving a regional anesthetic for a mastectomy. And then in another study, using NSQIP, which is newer data, same thing. You're seeing decreased odds, especially in non-Hispanic Black, which was 0.37. Odds ratio of receiving a regional anesthetic for mastectomy. Then you see the same thing with the NSQIP data again, where there was a decreased odds of regional anesthesia for total knee replacement, and then as well as a Hispanic population. When we look at hip fractures, it was getting regional anesthesia or hip fracture surgery. Black, there was decreased odds of receiving neuraxial anesthesia for that, and but no difference in peripheral nerve blocks. So again, what I want to point out, the limitations of these NISQIP papers is there's no specific institutional data. Everything is lumped together. So I can't see and say there's which institutions are seeing these disparities. And it's important because then we can look at these institutions and say, what's wrong with those institutions? Do they not have a lot of resources? What area are they in? So that's what we have to answer, right? And so we look at other data sets. There's one that's called the HCA Healthcare, very granular EHR data, but also limited in the terms of information about their individual hospital data. But again, we see those that insurance has a big role and race has a big role in those who are receiving regional anesthesia. And then when we look at the SPARCS data set, which is statewide planning and research cooperative system, this one had hospital level data. So now we can start looking at which patients belong to which hospital. Are we going to still see a difference? Because this will tell us that even within a single hospital there's disparities rather than if you clump all the hospitals together. And so what here you see here, decreased odds of getting regional anesthetic in the Hispanic population. And then we look at the premier data set here as well, which is a large data set. And you're able to also control for hospital level data. And you see that there is a increased odds of white population receiving regional anesthesia when you're looking at over almost 2 million patients getting a total knee replacement and almost 1 million patients getting a total hip replacement. But what I want to point out is that they controlled for hospital level data now. So now we're saying that even within hospitals, we're seeing this difference. Optum is a big data set, 67 million patients. Again, there's hospital level data, and this is very interesting because in this study, they showed that in this plot, what you're seeing is on the x-axis is listing different hospitals. Each dot is a rate of block administration per hospital. The x-axis is the percentage of Black population in that hospital, and the y-axis is the percent of regional anesthesia received. And you're seeing a downslope. So what does that mean? The more hospitals with a higher Black population as having a decreased use of regional anesthesia. And so now we're starting to see, that there is something happening not just at the national level, but at the hospital level. And so now, there are differences in racial and ethnic differences in regional anesthesia. We see that from these data sets. Are they perfect studies? No, but this is what we have. There's limitations. They're retrospective. Again, we don't have all the data in there, but we can surmise what's the reason this is happening and come up with some solutions. And so you think about a few key topics, right? There's structural racism, there's cultural and social barriers, implicit bias, geographic resource limitations and practices. And so we have to think about each of those things when we're trying to think of a solution. So as we know, implicit bias is hidden biases defined as assumptions we make about people, stereotypes, it requires conscious effort to interrupt bias. It has been shown to be shown in healthcare. And then we also look at cultural and social barriers. So we touched upon language barriers, cultural and personal perception of pain. We know that those are different. Understanding of information given to them, there's mistrust and insurance. And so these are things that we need to be sensitive about when we're thinking about mitigating bias. But a big one now that I always ask myself is, so you're seeing a lot of these hospitals that are using less regional, and in those hospitals, there's more, underrepresented populations. Is the reason because of race, of implicit bias, or is the reason because there's not a lot of resources in those areas? I don't know, but we have to think about all of those things, right? So we saw that in the Optum and Premier data sets that when you control for hospital factors, you're seeing a lot of decrease in, you're seeing potential for implicit bias and cultural bias. So I think all of this is together. Structural racism, cultural and social barriers, geographic resources, implicit bias. It's all important. And one way, some of the things we can tackle this is, the patient doctor relationship is not limited to how much the physician has studied and how smart they are. A lot of it is cultural connection, and that's why it's important to diversify the workforce, right? And what we're seeing is that we're behind on that. And actually, this is a great study that we published, Dr. Ume over here, when we looked at the number of underrepresented minorities in regional anesthesia fellowships. And what you see is that 57% of them had 0 in this, who filled out the surveys. 75% of them had no Black African Americans, 70% no Latino, so 50% no LGBTQ. So you're seeing that, and the reason why this is important is because if we want to create an environment where there's more diversity, we need more trainees in regional anesthesia, right? And so we need to work on that. When we think about it in reducing implicit bias, we touched upon this, is we got to standardize protocols, right? There's a study in early 2020 that showed that when they applied ERAS protocols to colorectal surgery, it actually decreased the gap in the outcomes between Blacks and non-Blacks. And so it's because they standardize protocols. So standardize is important within institutions, but we also have to share those protocols across institutions. But not every institution has the proper resources, right? And without the proper resources, they can't do regional anesthesia. And those resources include those who are trained in regional anesthesia. So what we need to do is actually, in further studies I recommend, is we look at those institutions that have low rates of regional anesthesia and more, underrepresented minorities, and see what are the resources they have. Do they have a lot of regional anesthesia experts? Are they doing a lot of regional anesthesia? And if they're not, why? And then how we can fix that. So that's essentially, we have to think about why there's disparities, and then target what we can do to actually fix that. And in summary, a big part of it is diversifying the workforce. It's figuring out who are the vulnerable institutions and what they're lacking, and work on a solution on that, and standardizing protocols, and then be very sensitive to why this is happening, and really researching more on how we can actually fix it. So, thank you.
All right, thank you all for coming. We maybe have time for one question. Fortunately, next session is going to be here in 15 minutes. So.
Yeah, I want to say thank you so much, Dr. Patton, for organizing this powerhouse panel. You guys don't know, these people are experts in regional anesthesia and acute pain management in their respective fields. So my question was to what Dr. Gabriel just pointed out. I myself am a regional anesthesiologist. I'm fellowship trained. So how can we get someone like me who's an expert in regional anesthesia to go work in a rural area, or to go work at Health and Hospital Elmhurst? I work in a hospital where 90% of my patients are white, and all of our patients get regional anesthesia. Why am I not choosing to go to work in a community hospital that takes care of 90% of Black patients? What's keeping me from taking my expertise to them, and how can we change that? Because we know that those hospitals don't have the same resources and they don't have the same experts. And all of us work at these institutions where we're not caring for our patients, with the exception of Dr. Archbold, who made the decision to go work at a community hospital to take care of minority patients. So how can we change that one factor?
I think it's a personal decision on where you want to work. And so I don't know, we could answer the question, why don't you do it? But why don't we instead find those who are already there and want to work there, and promote them to, hey, this is in your community that you've already chosen to work at, consider this specialty because XYZ, right? Instead of getting people that are comfortable where they are. I mean, I think it's important, but there's always reasons why you can't move to a certain area. But there are people already there that are going to work there, are committed to work there, and want to work there. Those are the people we should, promote.
Thank you.